Module Overview. Crisis and emergency situations often serve as flashpoints where trauma is most intensely experienced, re-experienced, or magnified. Whether responding to natural disasters, public health emergencies, violent incidents, family crises, or community-wide trauma events, trauma-informed responses must be swift, sensitive, structured, and stabilizing. This module provides a comprehensive, interdisciplinary guide for trauma-informed action during acute crises, offering critical frameworks that align with international humanitarian, clinical, social work, and public health standards. In moments of crisis, the urgency of the situation must never override the dignity, autonomy, or safety of those involved. Traumatized individuals may be hyper-alert, disoriented, withdrawn, or in survival mode. Traditional crisis response models often emphasize control and efficiency, whereas trauma-informed crisis models emphasize calm, connection, collaboration, and choice. Understanding crisis trauma. What makes a situation a crisis? A crisis involves a significant disruption in normal functioning, accompanied by high emotional intensity, fear, or confusion. This can include natural disasters, floods, earthquakes, war, or armed conflict, domestic violence incidents, suicide attempts or threats, medical emergencies, mass layoffs or displacement, child or elder abuse reports, community tragedies, e.g. shootings, fires, how trauma responds in crisis. People may freeze, fight, flee or fawn, exhibit emotional shutdown or hyperarousal, become verbally or physically aggressive, feel disconnected from reality, lose trust in helpers. Types of trauma in crisis: acute trauma, sudden events, complex trauma, ongoing stress, collective trauma, shared, community pain, secondary trauma, experienced by responders. Core trauma-informed principles in action. 1. Principle 2. In crisis settings, safety. Physical, emotional, and psychological safety are prioritized. Clear exits, calm tones, transparency. Trustworthiness, provide consistent updates and explanations. Avoid hidden agendas. Choice, offer small, meaningful choices, e.g., would you like to? Sit or stand. Collaboration. Include the individual in decisions where possible. Empowerment. Focus on strengths. Affirm their coping ability. Cultural, gender, historical sensitivity. Respect customs, language, spiritual needs. Example. During a natural disaster, allow displaced families to stay together, offer information in multiple languages, and validate their grief. Trauma-informed crisis communication. Do's speak slowly, clearly, calmly. Use people's names when known. Validate feelings. I understand this is scary. Avoid judgment or interrogation. Use plain language. We're here to help and keep you safe. Don't shout or bark orders. Don't make assumptions about coping ability. Don't minimize feelings. It's not that bad. Don't threaten or use force unless absolutely necessary. Remember, the goal is not just to manage the situation, but to preserve human dignity. De-escalation through a trauma lens. Traditional approach: control, authority, physical restraint. Trauma-informed approach: co-regulation, helpers manage their own calm. Use of grounding techniques and body language. Maintain open posture and non-threatening eye contact. Offer time and space without pressure. Example. Instead of forcibly restraining a yelling teen, a trauma-informed responder might sit at eye level, say, "I'm here with you. You don't have to talk right now, but I'll wait nearby if you need anything." Responding across different crisis settings. 1. Hospitals and emergency rooms. Prevent sensory overload, reduce noise, dim lights when possible, inform before touching, involve advocates, family if available. 2. Domestic violence shelters honor confidentiality. Let clients choose their own clothes or beds. Empower decision-making. 3. Police and law enforcement partner with social workers or crisis teams. Avoid excessive force or escalation language. Build rapport through empathy, not orders. 4. Child Protective Services. Explain steps to both children and guardians. Allow familiar objects, toys, blankets, engage play therapists or trauma clinicians early. 5. Community emergency responses. Create safe, quiet zones in shelters. Design intake procedures that ask about trauma histories. Offer mental health services in culturally relevant ways. Secondary trauma and staff well-being. Responders exposed to repeated trauma face burnout, vicarious trauma, and compassion fatigue. Organizations must provide trauma-informed supervision, encourage peer support, normalize debriefing and breaks. Watch for signs of trauma in staff. Irritability, withdrawal, numbness. Offer confidential mental health services. Documentation and trauma-informed language. Crisis notes and reports should avoid labeling, e.g., non-compliant, aggressive. Describe behavior factually. Client raised voice and walked away when offered help. Include client preferences. Avoid blame and medical jargon. Aligning with accreditation standards. To ensure crisis responses are aligned with global and national standards, this module reflects guidance from 1. Organization. 2. Standard highlights. WHO Mental Health and Psychosocial Support in Emergencies, IASC Guidelines. UNICEF, Child-Friendly Spaces, GBV Minimum Standards. Joint Commission, USA. Emergency preparedness must include psychological care and trauma-informed communication. SAM-HSA Crisis Care Continuum must be trauma-informed IFRC/Red Cross. Psychological First Aid, PFA Protocols. Sphere Standards. Minimum standards for humanitarian care, including mental health and safety organizations should integrate trauma training in emergency drills. Establish partnerships between emergency and behavioral health services. Ensure feedback loops from service users.